Welcome to the next segment in our series, College Conversations, Medicine, Science, and Society. Today, I'm speaking with Dr. Edith Mitchell, a fellow of the college since 2016 and current board secretary. Dr. Mitchell is the director for the Center to Eliminate Cancer Disparities and program leader of gastrointestinal oncology at Jefferson University Hospitals. Dr. Mitchell is a board-certified medical oncologist, has been practicing for over 44 years, and was the first woman physician to become a brigadier general in the United States Air Force. Last month, Dr. Mitchell graciously hosted the annual Mercy Douglas Lectureship, which celebrates the Mercy Douglas Hospital and its contributions to healthcare in the city of Philadelphia for the African American community. Welcome, Dr. Mitchell.
Thank you so much, Dr. Irons, and it is a pleasure to be here with you in this effort.
Great. So, Dr. Mitchell, I'll start by asking you to give a brief history of the Mercy Douglas Lecture at Jefferson, how it began, how all of the sponsoring organizations came together, and how it's evolved over all the years that you've led it.
When I arrived in Philadelphia and joined Jefferson, I made a big point of meeting and knowing the physicians in the community, and that included members of the National Medical Association, some of whom I knew from conventions and other methods, but many who I did not know. And they were very inspirational to me, one in establishing clinical trials where the community physicians could participate in. So I set up some implementation strategies to increase the number of African American patients on our clinical trials. And amid those discussions, I found out about the Mercy Douglas Hospital and how it had impacted healthcare in Philadelphia. I even met some of the original physicians of the Mercy Douglas staff, several of whom I had on the program last month. So in talking about the Mercy Douglas program, they had very few resources. And I thought, well, why not Jefferson host the program? So Jefferson's leadership immediately accepted the idea and provided support. So we had the program within the Cancer Center for many years. So once I joined the college and was active in college programs, we have discussed disparities in Philadelphia. And fortunately, the group works together so that we decided to collaborate together, the Sidney Kimmel Cancer Center at Jefferson, Thomas Jefferson University Health System, and the college with the Medical Society of Eastern Pennsylvania, which is the local society of the National Medical Association. So that it was just an opportunity to bring people together. And it was an opportunity for Jefferson as well, because most of the speakers that we have invited over the years had tremendous expertise, and they spent time on the campus with students that day. Particularly, we had Dr. LaSalle Lafall, who is just a giant in the medical community. Mm-hmm. Another of the Mercy Douglas speakers was Dr. Lou Sullivan. Dr. Sullivan, of course, is just one outstanding person who has never been replaced in all of the work that he has done. Dr. Sullivan was the director of Health and Human Services in the first Bush administration. He later established Morehouse School of Medicine, the third historically Black institution for medical school. We were so proud to have Dr. Lisa Newman as the speaker this year, and her expertise for all of us in Philadelphia. And collaboration in medicine, I think, is the methodology where we can learn from each other we can see each other, and our efforts all together are stronger by collaborative endeavors.
Oh, absolutely. Thank you. And the college was thrilled to be able to co-sponsor, the lecture this year with Jefferson. And thank you so much. But I totally agree with you. I think that when we collaborate across multiple organizations, all sort of moving in that same direction, we just multiply our efforts. It's harnessing the power of the profession to do the right thing. In the introduction to the event, we learned about three extraordinary physicians. Dr. Nathan Francis Moselle, a founder of the Frederick Douglass Hospital and the first African-American graduate of the University of Pennsylvania Medical School. Dr. Henry McKee Minton, superintendent and director of the Mercy Hospital for 24 years. And Dr. Eugene T. Hinson, founder of the Mercy Hospital in 1907. All of their portraits currently hang in the college, so we're honored to have that. How do you think about their courage and dedication and their legacy? And this is one of those thought experiments for you. What do you think they would say of where we are as a healthcare community today in addressing equity, disparities, and access?
So I was so enthusiastic and very privileged to know that their portraits were located somewhere here in the college, but not in a distinct location. And I think it's so important that we all recognize the importance and the courage of these doctors. Although Dr. Moselle was a graduate of the University of Pennsylvania and was tops in his class, he could not obtain a postgraduate training program here in Philadelphia because of the color of his skin. The same thing was true of Dr. Minton at Jefferson, top graduate at Jefferson, yet he could not obtain postgraduate medical training in Philadelphia. So I think that it's important for all of us now to recognize not only their courage, but their recognition that there was a gap. Yeah. And that gap affected individuals in Philadelphia. They didn't limit the care of the patients in these hospitals to Blacks. Mm-hmm. Anyone who needed medical care received that care. Certainly, they recognized that Blacks did not have appropriate health care. Therefore, I think it's so important that the college not only recognize their contributions, recognize their courage, and recognize their ingenuity, but recognize their status in the history of medicine. Not just medicine in Philadelphia, not just Black medicine, but medicine overall. So I was just so privileged. In the earlier years when I sponsored this at Jefferson, many of the individuals were still alive and they were so proud. One of them actually gave me the photograph of the medical staff at Mercy Douglass Hospital. It hangs in my office. And when we find a place at the college, I'm going to donate that to the college. I've had it restored and beautifully melted, so that will go to the college.
Oh, thank you.
And I thank the college and all of the members at the college for joining me in these efforts.
Thank you. Dr. Lisa Newman gave the Mercy Douglass lecture, and it was titled Oncologic Anthropology and Breast Cancer Disparities, which focused on the increased burden and morbidity and mortality of triple-negative breast cancer in Black women. And it was an outstanding lecture. And, I thought that the focus on anthropology was novel and raised this whole issue about how we think about race and ancestry in the clinical and research environments. And I think, you're aware that over the last few years, there have been discussions about race-based algorithms and how race is used in medical care with the focus on increasing the disparities. But one of her slides actually stated that while racial identity is a socio-political construct, and I think everybody agrees with that, it's also associated with ancestral factors that contribute to cancer burden because it's often a window into ancestry.
Correct.
So how do you think about that in your practice as an oncologist? How do you use the information that we get from ancestry and use it when you're counseling patients, knowing that a lot of it actually came from studies that were really focused on race?
So yes, Dr. Newman is a tremendous clinician, researcher, and she has traveled to Ghana and other African locations doing surgery, providing information, and she is the world's greatest expert in this area. So there is a lot of information about when the slaves arrived in America. Where were the routes that they chose from the African continent to the Americas? And those individuals came from certain areas of Africa, Ghana, one of the major sources of slaves. And many of the ships either traveled directly to ports in the United States or what is now the United States. This was even before the country was formed. And other ships from the same ports, many went to South American countries, particularly Brazil is one. And with genomic profiling of individuals as well as tumors, many of the unique genomic markers have been identified in other countries as well, such that there is a history of where slaves were traded to, and thus Blacks in those countries now. That is a large area of study. And you can actually, using your genomic profile, determine where your ancestors came from Africa. And because genomic profiling and precision medicine has allowed us to learn a lot about tumors, there are the research studies combining the two, ancestry and precision medicine, so that we understand a lot about tumors. And we find that there are some relationships with healthcare that are very important, not only for cancers, but for other disease processes as well. So it's a very enlightening area of research.
Do you think, to that point, the African American women with triple negative breast cancer usually present younger in age with a more severe form of breast cancer, more harder to treat? Do you think we'll ever get to the point in oncology where people are screened at different ages, where you begin screening earlier or have a different screening paradigm based on ancestry, really precision medicine, if so to speak? You think we'll ever get there?
So we're almost halfway there. And you've just described the NIH All of Us study, established by the former director, Dr. Collins. And the All of Us program invites participants to join the study. It does not call the participants patients because many have no evidence of any disease process. And he wanted 1 million individuals from diverse groups to join this program. It was established May of 2018. And I remember that vividly because some of us who were proponents of the study were around the country giving lectures on Join All of Us. It now has over 400,000 participants.
Wonderful.
It is one of the largest studies that NIH has ever attempted. And at this time, over 50%
Mhm.
of the participants are from diverse communities. So that incorporates
Right.
race, ethnicity, gender, socioeconomic constructs as well.
Mhm.
So that study is ongoing. The
Mhm.
nice thing about it is it gives back to the participants their information so
Mhm.
that they're able to utilize it
Mhm.
in their own information.
Mhm.
So, for example, if you have members of a family who've joined, there can be information about risk
Mhm.
of disease processes. And I think it's good if you know, for example, diabetes is in your family, having that information early,
Mhm.
or Alzheimer's or cancer. It's all so important for researchers
Right.
because researchers are able to submit proposals for research, get the information, and thereby add to the research database and the research that we know about individuals. So I think it's a great study. I spend a lot of time giving out information on all of us. And thank you for allowing me to talk about it
Happy to.
today, because
Yeah.
it's an important entity. And I encourage individuals to participate as an individual, but also for research groups,
Mhm.
participate as researchers.
Great. Wonderful. The COVID pandemic, has disproportionately affected African Americans and Latinx individuals and has reminded us all that we have a long way to go in addressing equity and health disparities in this country. What are your thoughts about how to address this problem so that we can, at some point, sooner rather than later, I hope, have a healthcare system that is equitable to all? Do you see progress in that area?
Oh, I absolutely do.
Okay.
I think TV,
Mm-hmm.
news media,
Mm-hmm.
and other forms of media has allowed us to understand more about people, locations, and the fact that African Americans disproportionately suffered from mortality from COVID. And that allowed conversation about mortality from cancers and heart disease, other conditions
Mm-hmm.
that African Americans suffered disproportionately on the outcomes and ultimate mortality for those conditions. Those of us in medicine knew that, but it brought it to the limelight for others in this country and allowed us to collaborate in the effort. So if we look at cancer screening rates, for example, they decreased tremendously during COVID. And currently, the NCI director, Dr. Sharpless, for example, has a manuscript where, using mathematical modeling, there is a prediction of higher mortality rates from certain cancers in the next few years because of the decrease in screening. But I think COVID was a very difficult situation and still is.
Mm-hmm.
But one of the benefits of the communications about COVID allowed for us to focus on disparities in healthcare
Mm-hmm.
and not only recognize the disparities, but implement some strategies going forward that may help us understand and change the opportunities for patients. So I think COVID allowed the United States really to focus on disparities in healthcare.
Yep. Thank you. So now, Dr. Mitchell, I always ask for final words. Are there any final thoughts that you'd like to end this wonderful interview with?
Oh, absolutely. I would like to say that collaboration
Mm-hmm.
in research and clinical practice is an important part of what we do. And we need to collaborate, bring them together, but also we need to collaborate in healthcare
Mm-hmm.
such that we're one. We don't have to talk about, in the future, I hope, disparities, because we will have implemented some strategies that allow for equal access to care,
Mhm.
that we will fix the disproportionate share of mortality by disparate racial and ethnic groups, that we increase the access to care by working with our health policy strategists, our congressional representatives, so that in the future we see us all as one, having not only equity in care,
Mhm.
but justice in access to care.
Mhm.
And I hope that is something we can all share so that we have a collaborative endeavor
Mhm.
to make sure that we are equal.
Great. Well, Dr. Mitchell, thank you once again. Thank you for being part of the college family. But even more than that, thank you for everything that you have done for clinical care of patients in Philadelphia and all of the national work that you do. I really can't thank you enough for taking the time to do this. I look forward to many more opportunities to talk about medicine and health equity with you. And thank you, everyone else, for tuning in with us today. And we will be back with you again in the future with another episode of College Conversations. Thank you.